Hello, welcome to today's webinar. We're going to give it another moment or two for people to join in. All right, so we'll get started. Hello, welcome to today's webinar. I am your webinar coordinator, Jonathan Dinkins. If you have any questions or concerns regarding to webinar technical difficulties, you can reach me at Q as in quiet, Z as in zebra, V as in Victor, the number 3 at cdc.gov. The Q&A box is for attendees. You all will be able to write your questions, and during the QA session, the department will get with you and answer your questions. And the recording will be available at a later date. So with all ado, we will get it started with Shayna. Go ahead.
It's actually Shreya's going to start.
Oh, sorry.
Yes. Good morning and good afternoon, everyone. My name is Shreya Kundia, and I'm one of the HAI epidemiologists, primarily working on the CRS response at the DC Department of Health. I also wanted to take this opportunity to introduce Candace Johnson, who is our interim HAI coordinator. If there's any questions about DC's HAI program, please send us an email at doh.hai@dc.gov. So that's from me, and with that, I'll pass it to Elizabeth.
Thank you, Shreya. Hi, everybody. I'm Elizabeth Vaith. I'm the Antibiotic Resistance Epidemiology Program Administrator with the Maryland Department of Health. I want to welcome all of our long-term care facilities that have joined today, and just assure you that we are really looking forward to working with you over the next coming months and years on implementing enhanced barrier precautions, and we are always available to help. So please feel free to give us a call after getting all of this new information today. We are here to help you implement. And I will pass it to Shayna Bernard.
I'm going to actually pass it to Massachusetts.
Hi, thanks, Shayna. Hi, everyone. My name is Katie Riley. I'm a public health nurse with the HAI AR team at DPH, and we are excited to be participating today. And I also will introduce Barbara Bolstorff, who's one of the lead epidemiologists on the HAI AR team at DPH. And again, we're excited to be here, and I will pass it to Shayna.
Thank you, Katie. And I just want to also say from the Virginia Department of Health, welcome. My name is Shayna Bernard. I am the Antimicrobial Resistance Coordinator for all of the Virginia facilities that have attended today. And I would like to echo everyone's comments that for any Virginia facilities, please reach out to our hai@vdh.virginia.gov mailbox for questions. I also have the pleasure of introducing our fantastic speakers for today. We have a great topic and some great speakers. So first we have Dr. Heather Jones, who is a nurse consultant with CDC's Division of Healthcare Quality Promotion. Her clinical background includes long-term care, acute care, and chronic care management. She has extensive experience in containment and reduction of communicable infectious diseases. Her primary focus is towards enhancing and improving infection control and prevention measures in these long-term care settings. Next speaker we have is Linda Bean, who is the Corporate Vice President of Infection Prevention and Control for Genesis Healthcare and has been certified in infection prevention and control since 2011. Linda has presented at APIC annual conferences on antibiotic stewardship, a novel technology to reduce UTIs and incontinence-associated dermatitis, as well as enhanced barrier precautions to control multi-drug resistant organisms and infection surveillance. She frequently speaks on infection prevention and control topics at state healthcare and other professional associations. Linda is a member of the faculty for AHCA's Infection Preventionist Specialized Training, contributing to the modules on antibiotic stewardship in nursing homes and water management plans. She served on the APIC Professional Development Committee and currently serves on the APIC Long-Term Care Task Force. Linda was a member of the technical expert panel entitled the Comprehensive Unit-Based Safety Program for Antibiotic Stewardship. And then lastly, we have Dr. Jacobs, who is an infectious diseases physician and medical epidemiologist in the Prevention and Response Branch within CDC's Division of Healthcare Quality Promotion. In her role at CDC, she leads the long-term care team focused on improving infection prevention and containing and preventing the spread of infection pathogens in the post-acute and long-term care settings through collaboration with health departments and partners, guidance and educational material development, and outbreak response. I will now turn it over to Dr. Heather Jones.
Hi, everybody. Thank you for joining us. I am going to stop my video while I'm presenting, just so I can maintain a good internet connection. So first, I'd like to let you know our disclosures. CDC, our planners, our presenters, and their spouses and partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. And here is a list of our objectives for today. So what is enhanced barrier precautions? Enhanced barrier precautions, or EBP, is the use of gowns and gloves during high contact care activities for high-risk residents as a means to disrupt multi-drug resistant organisms, or MDRO, spread. The use of EBP expands the use of personal protective equipment, or PPE, beyond situations in which exposure to blood or body fluids is anticipated. Use of EBP also reduces the necessity for a resident's restriction to their room.
Dr. Jones, can you speak up a little bit? We're getting
Yes,
some feedback.
Apologies.
Thank you.
Is that better?
It's a little bit better. Can you a little bit
I'm going
closer?
to try.
Okay.
I've been having some technical difficulties today, so I'm hoping this is better. When you are choosing to use EBP in your nursing home, the resident does not require a private room and the resident is not restricted to their room. Again, gowns and gloves are recommended for high contact resident care activities only. This includes dressing, bathing or showering, transferring a resident, changing their linens, providing hygiene, changing their briefs or assisting them with toileting, and it also includes indwelling medical device care or use and wound care. EBP is recommended to be used for the entire length of a resident's stay in the facility. I have listed here what types of facilities where enhanced barrier precautions is currently recommended. This includes nursing homes and skilled nursing facilities. It is not currently recommended in acute care hospitals, long-term acute care, assisted living facilities, residential care facilities, or group homes. On this slide, I show a breakdown of what types of situations EBP is recommended, as well as scenarios when it would not be recommended. The recommendations for EBP are for residents with wounds, regardless of MDRO colonization status, a resident with an infection or colonization with a novel or targeted MDRO when contact precautions do not apply, and any resident with an indwelling medical device. Enhanced barrier precautions is not recommended for any resident with draining wounds, acute diarrhea, or the resident has sites with secretions or excretions that are unable to be covered or contained. EBP is also not recommended on units or in facilities where ongoing transmission is documented or suspected. So now I would like to help with understanding why we recommend the use of enhanced barrier precautions. The use of EBP has the potential to disrupt MDRO transmission in a less restrictive manner. It allows for focusing on the reduction of MDRO transmission and spread, and not just for residents with a known active infection, and ideally reduces the silent spread of MDROs. We know that resident-to-resident pathogen transmission does occur, and this is in part due to healthcare personnel during resident care activities. We also know that residents in skilled nursing facilities and nursing homes are disproportionately affected by MDRO infections. The use of EBP allows for a more effective response to serious antibiotic threats. We know many of our nursing home and SNF residents have complex medical needs and therefore are at higher risk for acquiring MDROs, and standard precautions often have not been successfully implemented in nursing home settings. This slide provides an overview of studies conducted to see what type of activities tend to cause the most MDRO contamination on nursing home caregivers' hands and clothes. As you can see on the bar chart on the right, assisting with linen changes, transfers of patients, and aiding with personal hygiene cause the highest likelihood of MDRO contamination. We know the nursing home setting is the resident's home, and there is a balance we must find between resident quality of life and resident safety. Enhanced barrier precautions help to provide both by reducing the necessity of restricting a resident to their room and allowing them to participate in activities with others safely. This reduces feelings of isolation and continues to provide a means of reducing the likelihood of MDRO transmission. Now on this slide, who is familiar with these MDROs? Methicillin-resistant Staph aureus, ESBL, and VRE. Now on the right, who are familiar with these? Carbapenem-resistant Enterobacteriaceae, or CRE, multidrug Acinetobacter, or multidrug Pseudomonas aeruginosa. Looking at this slide and knowing many of these, you can see that these MDROs have gotten to the point of being, unfortunately, not uncommon in long-term care. That doesn't mean we don't need to worry about them. These still cause significant morbidity and mortality, can spread between residents, and their resistance to some antibiotics can lead to potential delays or challenges with treatment. Anytime we have a large group of people sharing limited or congregate space, there is an increased risk of transmission of infectious pathogens. Now consider the changing landscape of long-term care and the increasing complexity of the residents in nursing homes. Add in the burden of MDROs and the challenge of what may now be older facilities that were not originally built for the level of care currently being provided. You have the perfect opportunity for transmission. Frailty, comorbid medical conditions, and dependence on caregivers for daily activities are all factors that increase the risk of colonization and infection with MDROs among older adults. While older adults may be at increased risk of infection in general, nursing homes are providing increasingly complex care, so the risk factors that in the past may have been seen more in acute care hospitals are now much more commonly seen in nursing homes. Those with indwelling medical devices, lower functional status, presence of wounds are all at risk for colonization with an MDRO. as well as residents who have been on antibiotics in the prior 3 months, those who have used fluoroquinolones, which are levofloxacin or Levaquin, ciprofloxacin or Cipro, if the resident has a history of hospitalization, and older age and comorbid medical conditions. Studies have estimated that more than 50% of nursing home residents with indwelling catheters, especially urinary catheters, are colonized with an MDRO. And if you think about it, those that are more dependent, have indwelling medical devices, or have wounds tend to have more contact with healthcare providers. So many studies have shown there are often carriers of MDROs in our facilities that are unknown. These next few slides show a depiction of a large study known as the Shared Healthcare Intervention to Eliminate Life-Threatening Dissemination of MDROs, better known as SHIELD. This was completed in Orange County, California, and included a variety of settings, including skilled nursing facilities, ventilator-capable skilled nursing facilities, or VSNFs, and long-term acute care hospitals, or LTACs. As you can see here, the percentages shown on the right of the slide are the percent of residents with a known MDRO at the beginning of the study. In SNFs, there were 17% of residents with a known MDRO. VSNFs were at 20%, and LTACs were at 50%. For all facilities together, this totaled 23% of residents screened were known to have an MDRO at the beginning of the study. Now let's take a look at once the study was completed. As you can see, there was a significantly higher number of residents with an MDRO than were previously known. In the skilled nursing facilities, there were 58% of residents found with an MDRO. For the VSNFs, there were 76% of residents. And for the LTACs, there were 82% of residents found with an MDRO. It should be noted that on this slide, the percentages are a calculation of both known and previously unknown residents with MDROs. So in the study, there was found to be an MDRO colonization rate 3 times higher across all facility types at the completion when compared to the initial known MDRO status of residents and patients across facility types. Now that I've talked about the what and why, I would like to share how best to implement EBP. First, you must know your residents, both current and new. And if you already know, documenting their MDRO status. Know which residents have indwelling medical devices, as well as wounds requiring addressing. These should be consistently documented and updated and can be done by electronic or paper means, whichever way you find best for your facility and staff, and update your staff consistently and on a regular basis about these residents. Over the next several slides, I will talk about each of these: hand hygiene, PPE use, environmental cleaning and disinfection, auditing, and communication. Each have an important part in a successful implementation of EBP. We all know what hand hygiene is, but are we reliably performing appropriate hand hygiene? The use of alcohol-based hand sanitizer is recommended prior to and after performing any hands-on activity with the resident, as well as both before and after donning and doffing gloves, including and especially with high-contact resident care activities. You are recommended to use soap and water if your hands are visibly soiled before eating and after using the restroom. The use of PPE, or personal protective equipment, is vital, and we all know now how to appropriately don and doff. It is important to review with your staff when and what types of PPE are recommended during activities with residents, and to ensure you have continuous access to PPE at point of care locations. The third portion is environmental cleaning and disinfection. I want to note it is important to understand if the products you use in your facility are EPA approved for both cleaning and disinfecting, as some common products, such as bleach, are for disinfection, but the surfaces must first be cleaned with a different cleaning product. There are several EPA approved products that do both, and it may be of benefit to your facility to research these products. It is essential to focus on daily cleaning and disinfection of high-touch surfaces, such as bed rails, tray tables, or bedside tables, and IV poles, as well as consistent cleaning and disinfecting of non-disposable, non-dedicated equipment after each use, including but not limited to vital sign machines, glucometers, portable radiology equipment, transfer lifts, and shower equipment. It is also key to ensure your staff know the products used during cleaning and disinfection and know the correct contact or dwell time for the products to be on the surfaces in order to be effective. Work with your local or state health department or lab company to know your facility and regional epidemiology for a better understanding of what organisms are prevalent in your region to help in determining the most appropriate products to be using, and make sure, if you don't already have one, to establish a who cleans what list for all of your staff. There have been numerous visits completed in facilities that, when asked, staff either didn't know who was supposed to clean certain items or thought someone else was supposed to be responsible for the item, and the item was not cleaned or disinfected. For any of the previously mentioned items to be successful, you must audit, and although auditing takes time, it is one of the most consistent ways to ensure your facility is performing appropriate hand hygiene, PPE use, and environmental cleaning and disinfection. Again, this can be either electronic or paper, and it is important to share with your staff and leadership the results of the audits and provide real-time feedback. Communication is one of the primary keys for success with any implementation. You must incorporate your entire team with communication. When you have a resident transferring to or from another facility, unit, or hall, ask about the resident's MDRO history and current status, and make sure you share if you are sending a resident to another facility, unit, or hall. Always use the appropriate recommended signs for residents who require either transmission-based precautions or enhanced barrier precautions. It is not appropriate to only use a "Stop, See Nurse" sign on a resident's door, as staff will not understand what precautions need to be taken prior to entering the room. It is not only important to communicate within your facility, but also outside of the facility, with health departments and other healthcare providers and facilities. Using signs that are easily understandable and clear provides good communication to residents and families, as well as staff that may not be as familiar with the residents. So this shows you a depiction of common pathways for communication about a resident in a nursing home. First, you see what we call the common approach. This is not enough to reduce transmission, and is when patients are transferred back and forth without all the communication and necessary infection control actions in place. The second is a slight improvement called independent efforts, but is still not enough. And this is when some facilities work independently to enhance their infection control, but are not often either alerted to MDROs from other facilities or informed of outbreaks in the area. The third and most appropriate and much needed approach to reduce transmission is the coordinated approach. This approach incorporates all and includes the public health department's tracking and alerting healthcare facilities to MDROs coming from other facilities, as well as outbreaks in the area, and facilities and public health authorities share information and implement a shared approach to infection control actions to stop the spread from facility to facility. One last tip is to use the educational resources you have available. Check with your local and state health departments for resources, as well as CDC's website. And don't reinvent the wheel. Remember to provide numerous ways for learning for your staff and give and receive feedback for improvements on current educational practices. Now that you know the ins and outs of EBP, I want to pivot and talk about limiting further transmission. This will go into remembering and understanding the times to use standard precautions, transmission-based precautions including contact precautions, and when it is appropriate to use enhanced barrier precautions. Many of us have been using precautions geared toward reducing transmission of COVID-19 for over 2 years now, so I would like to provide a reminder about what standard precautions are. Standard precautions are used in all settings and with all residents, not just the ones that are considered high risk. It is in place to protect you and the resident. Gloves should be worn when it can be reasonably anticipated that contact with blood or other potentially infectious materials, mucous membranes, non-intact skin, or potentially contaminated intact skin could occur. For example, providing care to a resident who is incontinent of stool or urine. And remember, hand hygiene is expected to be performed both before your gloves are donned and after your gloves are doffed. Gowns should be worn during any procedure or resident care activity that may involve contact with blood or body fluids, secretions, or excretions. Masks, goggles, or a face shield is recommended during any activity likely to generate splashes or sprays with blood, body fluids, secretions, or excretions. And again, this is for all settings and for all residents. Contact precautions. These can apply to all settings with specific residents who meet the criteria for contact precautions and is used for every room entry. Contact precautions include the use of gowns and gloves and is intended for residents with C. diff, scabies, norovirus, or any other conditions where contact precautions is currently recommended. If the resident has the presence of acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be covered or contained, contact precautions would be recommended, as well as for units or halls where ongoing transmission is documented or suspected. Residents who are on contact precautions should be placed in a private room, and again, gloves and gowns are recommended for every entry into the room and for all activities being performed in the room. The residents should be restricted to their room except for medically necessary movements, and contact precautions are intended to be time limited, meaning the precautions should be used to reduce transmission during a limited infectious period or during periods of high risk of transmission, such as with a recent acute care hospital stay. For enhanced barrier precautions, this is currently recommended only in nursing home settings, including skilled nursing facilities, and apply to residents with specific situations and only require the use of gowns and gloves during high contact resident care activities. Currently, residents with an infection or colonization with a novel or targeted MDRO, when contact precautions do not apply, may be placed on enhanced barrier precautions, as well as any resident with a wound requiring a dressing or an indwelling medical device, regardless of the MDRO colonization status, who reside on a unit or wing where a resident known to be infected or colonized with a novel or targeted MDRO resides. Again, residents on enhanced barrier precautions do not require a private room. Gowns and gloves are recommended only for high contact resident care activities. The residents are not restricted to their rooms, and the precautions are recommended for the resident's entire length of stay in the facility. So I wanted to provide a couple of scenarios for you to think through. The first one is that you have a resident who lives in a nursing home who has had acute diarrhea for 1 week. He currently has a tracheostomy and is colonized with VRE. The acute diarrhea resolves after 1 week and does not recur. There is also currently no known or suspected transmission of MDROs in the facility. So the first question, what type of precautions, if any, would you recommend for the resident while he has acute diarrhea? So the resident would be recommended to be on contact precautions during the time of having acute diarrhea. The second question, what type of precautions, if any, should be used after the resolution of the acute diarrhea? At this point, it would be recommended for the resident to be transitioned from contact precautions to enhanced barrier precautions because of the presence of the tracheostomy and VRE. So how long should the resident be on precautions, if at all? The resident should remain on contact precautions while having the acute diarrhea, and once transitioned to enhanced barrier precautions, it is recommended that the resident remain on the enhanced barrier precautions for the resident's stay in the facility unless the resident develops a condition that recommends for the use of contact precautions or other transmission-based precautions. The second scenario is a resident of a nursing home has had an indwelling urinary catheter to promote wound healing. The wound is now healed, and the indwelling urinary catheter has been discontinued. The resident has no other wounds or indwelling medical devices. This is the same facility as the first scenario, so no known or suspected MDRO transmission is happening, but there is a resident on the same hall as this resident with a carbapenem-resistant E. coli. So the first question is, what type of precautions, if any, would you recommend for the resident while she has an indwelling urinary catheter? So the recommendation while she has an indwelling urinary catheter is enhanced barrier precautions. Why? The resident currently has an indwelling medical device, and there is a resident on the same hall with an MDRO. Again, as long as the resident has an indwelling medical device present, it would be recommended to continue enhanced barrier precautions. Once the resident does not meet that criteria any longer by having the indwelling urinary catheter removed, then the resident would be removed from enhanced barrier precautions and would be able to use standard precautions. So the final scenario and question, do residents placed on enhanced barrier precautions for a novel or targeted MDRO require placement in a single-person room? No. Single-person rooms should be prioritized for residents required to be on contact precautions. Residents on enhanced barrier precautions may share rooms with other residents. And if you do have a situation in your facility that there are multiple residents with a novel or targeted MDRO, you could consider cohorting them together on one wing or unit to decrease the movement of healthcare providers between residents. But when using cohorting strategies, it is important to adhere to all recommended infection prevention and control practices, including any transmission-based precautions or enhanced barrier precaution recommendations that are in place before, during, and after each resident's move, and, if able, maintain the same staff for the cohorted residents. So lastly, I wanted to remind you of where and when enhanced barrier precautions is currently not recommended and in what situations. It is not recommended for residents of long-term acute care hospitals, assisted living facilities, residential care facilities, or patients in acute care hospitals. Residents with acute diarrhea or an inability to contain excretions or secretions should not be placed on EBP. Residents with conditions where contact precautions are recommended should not be placed on EBP, as well as any facilities with units or wings that have ongoing or suspected MDRO transmission. I will now turn over to Linda to talk about her pilot with Genesis.
Thank you, Heather, and good afternoon, everyone. Next slide, please. So I'd like to share with all of you a pilot project that Genesis Healthcare collaborated with the CDC on regarding enhanced barrier precautions. During the pilot, residents were selected to participate if they met the EBP criteria listed on the slide. We created a dedicated and detailed implementation plan for the centers. And it took them about 2 to 4 weeks for each participating center to begin implementing the plan. Once implemented, they were using EBP on their units for about 3 months. Unfortunately, we had to end the pilot prematurely due to the rise of COVID cases in early 2020. Next slide, please. So during the pilot, we really wanted to measure the outcomes that you can see listed on the slide. We wanted to see and measure staff adherence to EBP practices. We wanted to obtain staff, resident, and family member feedback. We wanted to have a better understanding of what type of residents were meeting EBP criteria. Would we have any change in hospitalization or infection rates? And what was really the burden of implementing EBP, including the cost? Next slide, please. So in the pilot, we had a total of 10 skilled nursing centers participate. 7 of them were located in Pennsylvania and 3 in Rhode Island. Now, 2 of those centers had mechanical ventilation units, and 9 centers had both short stay rehab units as well as traditional long-term care units. 1 center was what we called Power Back Center, meaning that that center had all private rooms and their residents were only short stay. So there were no long-term care residents in that facility. And the number of beds per center ranged from 106 to 238. Next slide, please. So one major difference in the EBP project was that we applied EBP not only to the novel and targeted MDROs, but to all MDROs in the center. And this was really done for two reasons. One was the belief that we should be controlling all MDROs. And second, we only had a limited number of novel or targeted MDROs in the centers. We also knew that if we followed a traditional approach, where you might educate on a new policy and procedure, and then state a date to have it implemented, that if we use that traditional approach, the process would fail and it just would not be sustainable. So from the beginning, we designated a QAPI approach, specifically using the Plan, Do, Study, Act approach. So the centers prioritized their units and implemented EBP on one unit at a time. This allowed for a controlled approach, and they learned about issues and solutions as they moved unit to unit. So by the end, the center had implementation and workflow for the staff well established. Next slide, please. So as I mentioned earlier, we provided centers an in-depth implementation guide to assist them in planning on how to best implement EBP in their centers. And it took centers a couple of weeks to prepare prior to the actual implementation. Centers were asked to consider all the areas that you see listed on the slide. So for example, under planning, they needed to set up their QAPI subcommittee. They needed to determine the sequence of units to implement EBP on and have target end dates for each of those units and the pilot as a whole. They needed to figure out who was going to order supplies and stock them. What would be the location of precaution signs, PPE carts, ABHR dispensers, and disinfectant wipes. And centers were required to review their progress with implementation as a standing item in their QAPI meeting until it was not only fully operational, but also habitual. Next slide, please. Before initiating EBP on a unit, we learned through experience, it is best practice to educate and inform the residents and their families about the increase in staff use of gowns and gloves. Not doing this can create fear and panic, especially among family members thinking that there's something terribly wrong on the unit. We created a resident family one-page education document that speaks to the use of gowns and gloves from a resident safety perspective. After all, that is what this is all about. It does not mention MDROs nor enhanced barrier precautions. To help explain the use of gowns and gloves, we use the analogy of the honeybee, which everyone can relate to. The honeybee travels from flower to flower, picking up and depositing pollen. Our staff, as they care for each resident, pick up germs and can deposit those germs on the next resident or in the resident's room. And we don't want our staff to be honeybees. So this is all about protecting residents from other residents' germs. We also found it very helpful to target our education to specific groups rather than having one generic education program. This way, we could tailor the messaging to the needs of that specific group. Next slide, please. So one component of the education provided was regarding the importance of planning one's workflow. We emphasized the think, plan, bundle, and finally do. The idea was to have staff think about what they were going to do, what supplies were going to be needed, and for the nursing staff, what residents they were assigned to care for. We emphasized the need to bundle care. Plan to do as much as you can for the resident and with their environment while you were in the room to avoid having to go in and out several times, which would increase the use of PPE. Next slide, please. In preparation for this presentation, I went back and had a discussion with Tara Winter, the Center Executive Director or Administrator of Chapel Manor, about Candida auris residents. Chapel Manor participated in our pilot and currently has a Candida auris resident and is working with the Department of Health to admit more residents with this organism. I asked her, why take on these residents that other centers are reluctant to take? And what makes her feel comfortable to do so? And what about cost concerns? So I want to share with you her positive point of view that may encourage your centers to embrace these residents that need our care. One, she considers herself a progressive leader. And by caring for these residents, it made her center stand out as being different in her market. She found by taking these residents, it opens the door to develop much better partner relationships with hospitals and the Department of Health. And I'm sure as center leaders, you found, just as she does, that if she tells her staff, we can do it, the team believes that they can. Next slide, please. The other thing that she really stressed was she felt that she had a superior relationship with the Philadelphia Department of Health. The Department of Health has been extremely supportive. She feels that, if centers embrace the Department of Health, the Department of Health is going to embrace you, because after all, the Department of Health wants you, your center, to succeed in the care of these patients and residents. Next slide, please. So this slide provides an overview of why the residents that participated in the pilot were placed on enhanced barrier precautions. As you can see, most residents had an indwelling device or wounds or an MDRO that was not on the novel targeted list. Only a very small number actually had a novel or targeted organism. Next slide, please. You can see that the proportion of residents meeting EBP criteria varied based upon the type of center. Notably, the percent of residents meeting more than one criteria also varied. So as you can see there in center number 1, this center mostly had long stay residents. They did have a short stay unit, and it was a fairly large center with a census of 238. When you looked at the residents that met the criteria, you can see most of them had an MDRO at 55%, followed by a wound at 44%, and some type of medical indwelling device at 35%. But notice how about 30% met more than one criteria. So they might have had a wound and a device, or a wound and an MDRO. Center number 2 was that power back that I spoke about, which had only short stay residents. These residents had an average length of stay of 2 weeks or less, and that center census was 110. Now notice the real difference here. Residents with an MDRO was 20%, wounds were only 10%, devices was the most at 70%. And notice that none of their residents met having more than one criteria. Center number 3 was one of our vent centers. So they had a mix of long and short stay residents, and their center had a census of 130. So here, the MDROs were at 59%. Wounds were 44% of the residents on EBP, and devices was 54%. But notice here that their center had the largest number at 50% that met more than one criteria for being on EBP. Next slide, please. Now, in terms of costs, some of our general findings regarding costs are listed here on the slide. I'd like to really point out the startup costs were greater than the maintenance costs. So since obviously more patients were being placed on precautions, the center therefore needed to order more PPE, which then required more storage carts. We needed more alcohol-based hand sanitizer. And so those startup costs, were really important. And so what we found then was that it was really challenging to predict the PPE utilization because those supply purchases may have been an overestimate. So when we actually monitored the costs month over month, we saw in the very beginning this very large cost, right? Because everyone was buying all the supplies that they needed. But we then think that they overestimated because over the following months, those costs mostly came down and were much less than that initial burden. And they kind of stabilized then. Next slide, please. Some additional feedback from the administrators was to spread out implementation due to budget constraints when you're buying all of those. I can tell you that the centers got creative. They went and looked at various types of PPE carts. And so I know some of them found, I believe at a Walmart, for example, that they could find a cart that was thinner, but yet larger, that sat in their hallways much better, and yet held more PPE so that the stocking of that cart did not need to be done as frequently, and it held enough PPE that you could stagger the carts to be between every 2 to 4 rooms. There was, for one of the 2 vent centers that participated, that one vent center also found that they needed to increase the frequency of trash pickup. They had been getting trash pickup, I believe, once a week, and they had to bump it up to twice a week. Next slide, please. So on this slide here, you can actually see the comments from both staff and residents, and that there was a real evolution in the feedback that we received as staff especially learned how to integrate EBP into their workflow and understand the use of EBP. No residents or families refused to participate in the pilot, nor did they express concern about the staff use of PPE. So you can see in November, when we very first started, you know, the staff were saying, really, we need to put this on like all the time. It's just too much to put it all on every time. And they felt like everyone was being admitted with an MDRO. But then notice in February, the staff saying, you know, in the beginning it was hard. I had to go in and out of the room because I would forget something. But then I got used to it. And it made her plan ahead. That was the bundling that we talked about. So she now thinks about, you know, what is she going to do? What is she going to need? And now she said it's not bad. And we've heard many staff say it did not add time to their work, because that was one of the concerns of center leadership, that with the staff having more patients on PPE, having to take gowns and gloves on more often, that it was really going to interfere with the amount of time they were spending. But the staff feedback was different. And you can see there that from the residents' perspective, they didn't mind at all. Patients that were coming from hospitals, they were used to the hospitals wearing a PPE, so they felt very comfortable with us doing it. None of the residents said that it made them feel bad or any type of negative feelings. And as I said, no residents refused. So I'd like to thank you for having me participate today. I hope I have provided you with some insight into how you may implement EBP in your center. I'd now like to turn it over to Dr. Slivka.
Thank you so much. Thank you, Linda and Heather, for the presentation so far, and thanks everyone for the questions you have coming in. I just have a couple of slides that I am going to share with all of you, and then I know we're almost at 1 o'clock. I think most of us are on the same time zone, but we're almost at time. But we are actually happy to stay for a little bit longer if you are able to stay, just to try to get in some more of your questions. Next slide, please. All right, so enhanced barrier precautions came out in mid-2019, and it was actually around that same time that we asked HICPAC. HICPAC is the Healthcare Infection Control Practices Advisory Committee. And this is essentially an advisory group that has experts that provide infection prevention advice and guidance to both CDC and the Department of Health and Human Services, or HHS. So we asked this group to put together a post-acute and long-term care specific work group to think about enhanced barrier precautions and to tell us about how this may possibly be more beneficial across nursing homes. And so this group actually came together, reviewed all of the available literature, and they put together a white paper that HICPAC overall supported that made some changes to enhanced barrier precautions to actually broaden the use of it. So I do want to add that this group specifically, this group of experts included experts from the nursing home industry, from academics, from clinical medicine, from public health, federal government. I think that captures just about everyone. But what they recommended was that EBP may be applied when contact precautions don't otherwise apply to residents with wounds or indwelling medical devices, regardless of their MDRO colonization status, and infection or colonization with an MDRO. And so that might not look super different than what we've already been talking about, but next slide, please. The key differences that I want to point out is that the 2019 enhanced barrier precautions, the current guidance that is available on our website, focuses on public health response. It focuses on situations where a resident was identified to have a novel or targeted multi-drug resistant organism, and then an outbreak investigation ensues, and you are trying to target those precautions, enhanced barrier precautions, to the highest risk residents, those with wounds and indwelling devices, as well as those who are found to be colonized with MDROs. And the recommendations for expanding this was really to not focus only on public health response, because we know that the burden of multi-drug resistant organisms is a challenge across nursing homes. And to not focus only on novel and targeted organisms, to take an approach that is actually very similar to what Linda was just describing with their pilot experience at the Genesis facility, their centers that participated. So these, the use of enhanced barrier precautions, again, when contact precautions don't apply, is that same residents with wounds and indwelling devices, as well as with an MDRO. Next slide, please. I'm quickly running through because I want to make sure that we leave some time to discuss. But what I've included here is, in this top table, is the list of targeted multi-drug resistant organisms that, or multi-drug resistant organisms that CDC targets. These are the organisms that are specified in the current guidance that I've been mentioning from 2019 that is posted online. But what has been put forward is that EBP actually may be more beneficial to all of us, to residents, and to preventing the spread of multi-drug resistant organisms if we expand the use to include other epidemiologically important MDROs. And so I've listed some of them on this table here. Next slide, please. So essentially, in what we are working on right now with our 2019 guidance is updating that guidance to align with the white paper and the advice coming out of that HICPAC work group, with no longer only focusing on targeted or novel MDROs, and no longer focusing solely on outbreaks or public health response situations, but to using enhanced barrier precautions, the targeted use of gown and gloves for those highest risk residents and the highest risk care interactions more broadly. So we are working on this and wanted to give you a little bit of a preview as we talk about enhanced barrier precautions, because we will be talking about this more, anticipating into the summer in the next couple of months. And then while I still have the mic, I wanted to at least address, there was a question that I saw that came in specifically about whether or not EBP was applicable to settings such as assisted living or some other settings. And what I can share is that we actually have a similar question of whether or not an approach like enhanced barrier precautions could be beneficial to settings outside of nursing homes. And so there are a lot of people right now taking a look at whether this is something that we could consider in a whole variety of settings, but including settings like LTACs or assisted living. There have been a couple of situations where we have already made sort of individual recommendations that may be approach that is a reasonable approach to take one-on-one in individual settings, but as of yet, we have not made those recommendations more broadly, but are investigating whether that is something that we should be considering. And so I will pause there for the moment. I'm not sure if we should go ahead and just try to start answering some questions, or I'll pause and see what you all want to do next.
Well, while we're waiting to decide, I can just say that there's a question that asked about Genesis. Am I implementing this in other centers? And I can tell you that, yes, we've implemented EBP in all of our centers. The difference being from the pilot, our current policy and procedure focuses on the novel and targeted, since that's the current guidance, versus the pilot was all MDROs. So when the CDC updated guidance comes out, certainly we'll update our current Ppe.
And I will go ahead and just also start to try to answer some of these questions. There was a question that came in about if a facility is having an MDRO outbreak, all residents with the MDRO should be on contact precautions in a private room. Correct, or so asking if that is correct. And so right now, our guidance does recommend that if there is a situation where we think there may be transmission that's happening, we think this is still an outbreak investigation, that contact precautions may be the best initial precautions to use until we sort of get in, figure out what's going on, slow down transmission, and then ideally transition someone into enhanced barrier precautions in the future. And this is something that we definitely recommend, and I welcome even input from our public health colleagues on the line. There may be situations where there are individual decisions that are made here, but we definitely say in more of the long-term situation, when you have someone who is colonized with a multi-drug resistant organism and they're not symptomatic, they do not have an active infection, they don't have another reason such as some kind of draining wound or copious secretions, something that they can't contain and you're worried increases their risk of spreading that MDRO. If those things aren't in place, then enhanced barrier precautions may actually be the best approach to both allow them to have the freedom to still go about their routines and leave their room and socialize with others, but also try to prevent spreading whatever pathogen they have to other residents. And so then the second part of the question, what about residents on the outbreak unit that are not known to have the MDRO, but have indwelling devices or other high-risk factors? Yes, EVP is recommended for those individuals. Those are the highest risk people for getting an MDRO, and we really want to prevent that. Because when people become colonized with an MDRO, they then have an increased risk of developing a serious invasive infection with that MDRO. And those infections are very difficult to treat and can ultimately be very dangerous, and possibly individuals with these invasive infections sometimes end up dying from the infection. And we really want to prevent that. So I will try to read through these questions live here. So I have a patient on contact precautions due to CRE with no active infection or signs or symptoms of infection on a unit with all residents with ventilators and catheters. So to take this patient off contact and place them on EBP would mean the rest of the unit would need to be on EBP as well. So what I will say is what we recommend is for someone who has that history of MDRO colonization, even if they don't have active infection or signs or symptoms, EBP is a way that you can still decrease the risk of transmission by having the people who are caring for them and are involved in those high contact, prolonged contact activities where the potential for transfer of that CRE from the resident, from their environment to that staff person who then may move on to the next room, going about their job. Wearing gowns and gloves and performing good hand hygiene decreases that risk, but EBP also allows that resident to have a little bit more flexibility and freedom, and having, coming and going from their room if they're able to do so. But yes, we definitely recognize that when there is a unit such as a ventilator unit where a lot of residents have indwelling devices or are on ventilators, these are the individuals who, many of them, if not all of them, may meet criteria for enhanced barrier precautions. And that is a lot of people who have that increased requirement for use of PPE, but those are the same individuals where when we go in and look, we find that sometimes 80% of them are already colonized with something. And over time, that spreads around and people become colonized with multiple different pathogens. And we find that spreads then to even other residents in the facility. So this is probably the highest risk group that we really want to target. And I'm going to keep reading through, but I welcome anyone if there's I'm going from top to bottom, but if there are any lower down that anyone would like to comment on, I welcome you to do so. Oh, Linda, you're on mute if you are.
Yeah. I saw one about cleaning and disinfecting in the nursing department, if there was anyone that was put in charge of equipment like vital sign machines or lifts that were used by the entire unit and not specifically assigned to a resident. How was the effectiveness of the protocol check? And was one person assigned to check or an honor system? So I would say at least that it was a mixture. Most centers assigned like a CNA to sort of keep a watch on what was happening. Also to be checking the supplies. So if we saw that, wipes weren't being used up, we knew, right, that they weren't really being used frequently enough. So it was a mixture of checking as well as the honor system. In terms of, I see one with residents with MDROs that are not infected. How are facilities keeping PPE available or staff at point of contact? So again, at least I can only speak for our centers. Many have various PPE carts that they put in the unit depending on the size of the carts. Some of the carts can meet the needs of every 2 to 3 rooms, or 4 rooms, I should say. There are some that had wall units. I will remind people of both life safety as well as ADA codes because they do say slightly different things, and they do specify if you put things in the wall, different codes talk about how much they can protrude and the height of them. So you just need to be careful that way.
Yes, thank you, Linda. I saw that question and thought of you because we have learned so much through all of your experiences and the differences center by center in terms of what worked best for them. I think one of the, sorry.
Sorry, Kara. I was just going to mention, I do see one question here that we haven't addressed. And it's if a patient has an MDRO that is not novel or targeted and the contaminated secretions are contained, would you recommend putting this person on EBP or contact precautions? So at this time, although the enhanced barrier precautions are still recommended for novel or targeted, once the HIPAC white paper came out on enhanced barrier precautions, it does allow for you to place the resident on enhanced barrier precautions. Granted, ensuring that that resident is able to contain those secretions or excretions. So yes, by having an MDRO or a history of an MDRO, it would be recommended for them to be on EBP.
Thank you. And I think we might have addressed all of the questions that have come in so far.
There was one that just came over. I'm not quite, I guess if someone has MRSA in a joint, maybe in the shoulder, if they do have a targeted or novel MDRO, it is recommended for them to be on enhanced barrier precautions.
And then I just saw a comment coming in from Lynn. So one of the thing is that with acute care hospitals, one of the differences is that acute care are placing these patients in contact precautions. The challenge in nursing homes is that contact precautions long-term is just not, it is not a great option for nursing home residents. For short-term, it is, but for long-term, really to follow contact precautions, the recommendation is that for any entry into the room, staff are gowning and gloving, they're performing hand hygiene and doffing that every time they leave the room for any entry. Really, that is the recommendation, and that the patient or the resident is staying in their room, because we have concern that they are going to be even more actively potentially transmitting whatever this pathogen is. We want them to stay in their room. We want care to come to them. We want them to not be leaving unless they absolutely need to. And so to do that for months on end for someone who is colonized, and that colonization status is a long-term thing, contact precautions is very isolating. And so enhanced barrier precautions is a way to try to continue to decrease the risk of spreading that multi-drug resistant organism, but do it in a way that is trying to make it more feasible to perform longer term. So in hospitals where the length of stay is often much shorter, I think average length of stay is still between 4 to 5 days, or somewhere around 4 days at this point. Maybe it went up a little bit with this pandemic. They put people in contact precautions and they maintain it the whole time. I will share that there have been people who have been interested in thinking about an enhanced barrier precautions approach, even in acute care. But right now they are able to use contact precautions because for them, people come in and out relatively quickly. But in long-term care, the length of stay is so much longer, and contact precautions for such an extended period is really challenging. So this approach is trying to make that balance between resident safety and resident quality of life, as Dr. Jones was saying. And it is really trying to decrease the risk overall by focusing on the highest risk residents and those highest risk care activities. So just walking into the room to quickly do something is pretty low risk. But going in to help someone get out of bed and help them get dressed and, bathe or shower, these are things that are much more hands-on, where people are in close contact for a longer period of time. And so for those high-risk residents, when doing that prolonged care, those are situations where we want to add that layer, that barrier, to try to prevent transmission. And I think that may be all of the questions, but I also want to say that we are more than happy to continue to hear from you all. We continue to think about and study enhanced barrier precautions in nursing homes, because we want to continue to be able to refine these recommendations for you all. So hearing from you is really helpful for us. And also we are happy to continue to answer questions, and we will have more resources coming your way as we move towards some of those updates that I started sharing at the end of the talk. I think we just want to make sure, for those of you who are still on, that you understand that you are able to obtain CE for listening into this talk. The details are at this link, and the access code is available here. You have until May 9th, so a little over a month, to go in and obtain that CE. And we, I believe, will make the recording available and should be able to share a version of the slides for you if that is helpful. So thank you all so much for joining us. We love having the opportunity to share with you and to hear from you and answer your questions. Thank you again so much for all of the care that you provide for your residents and for being here. Thanks.